Hello everyone, welcome to the Ultrasound Pathophysiology of Shock seminar. We are working today in this lesson about different kinds of shock, different patterns of shock, different treatments even for specific kinds of shock, and especially to understand what's inside pathophysiologically under the shock. So the shock begins with a definition, and almost all the universal definition of shock includes the concepts low blood perfusion and tissues. So for obtaining an adequate blood perfusion to tissues, there are two main factors implied. One is the cardiac output, and the second is the flow resistance. If we are working in a really basic definition of cardiac output, we can we can define that the cardiac output is the blood pumped out by the heart, especially the left ventricle. For the cardiac output, there are two main factors implied as well. One is the heart rate, and the second is the stroke volume. So the cardiac output is the first term, the first concept implied in the blood perfusion. The second is the flow resistance. There are two different vessels here, actually are pipes. So there's two physical concepts assessing the flow resistance or related to the flow resistance. One is the vessel's length. We can say that in the body, the vessel's length will be always the same somehow. So the main measurement implied in the flow resistance is the vessel diameter. So in both pipes with the same flow, the first one will have more pressure, and the second one will have less pressure inside. So there are three main factors in real that are affecting the perfusion. One is the presence or absence of blood. The second is the pipe itself, which is the vessel. And the third one is the pump, the heart. So there are different kinds of shock. The hypovolemic shock, the distributive shock, cardiogenic shock, or obstructive shock. Both the first two ones, the hypovolemic and the distributive shock, are affecting the blood or the vessels, and the cardiogenic and the obstructive shock are more related to the heart and the surroundings of the heart. The first one, we need to take in mind what's a very basic definition of cardiogenic shock, which can be this one. The heart is unable to pump blood. Under an universal definition of cardiogenic shock, we are talking the concept of about no squeezing or lack of strength. There's a lack of contraction strength. So cardiogenic shock, by the way, what kind of view is this? This is a parasternal short axis in which we are evaluating the squeezing at the level of the pupillar muscles or terminal cords. We see the squeezing perfectly, the walls come together, both in between them, and the myocardium enlarges in a uniform way. So it's totally different than this situation in which there's no contraction. We don't need to take some numbers, we don't need to measure nothing, because with just eyeballing, we are considering there's no contraction here. This view, which is the parasternal long axis view, we're assessing two things. One are the walls coming down, and second, look at the mitral valve, especially compared with this. So the walls the walls doesn't not matter, no movement at all, and the mitral valve does not open. And this is not a valvular problem. The problem is the lack of strength, the lack of a steam, of a flow that opens the valve. So it's a problem of no contraction. The cardiogenic shock, we are going to assess the wall motion globally, which is called the ejection fraction, and the valvular motion as an indirect indicator of an abnormal wall motion, abnormal ejection fraction. But there can be another causes of cardiogenic shock as well. This is a clip. It's an apical parasternal short in which we are seeing at least a descent contraction, but the heart rate is not too normal. This is extreme bradycardia. And this is the second cause. This, by the way, is a succinctoid view with the liver and the four chambers. And this is going too fast to obtain an adequate ejection fraction. So other causes. Number one, arrhythmias, the succinctoid body view. Other causes as well. Look at the valve that is unable to close, and there's a flail of the posterior leaflet of the mitral valve. So valvular causes can be the cause, the etiology of a cardiogenic shock as well. The obstructive shock. We are talking about obstructive shock if the patient, the clinical condition is physical obstruction or vessels or even the heart itself. And the most weak part of the heart is the right side, especially the right ventricle. Possible causes, cardiac tamponade, massive pulmonary embolism, or tension pneumothorax. Those are affecting the right side of the heart and causes that the right side of the heart is unable to have an adequate right ejection fraction. Tamponade. In our environment, in our clinical environment, in our daily practice, for having a tamponade, we need fluid around the heart. Like in this case, there's a succinctoid view of the heart, and the heart is totally surrounded by a black an anechoic structure, which is fluid for sure. But we cannot assess just the quantity, because the quantity is important, but this is not the most important issue, the most important thing we have to evaluate for a tamponade. Because in the new case, in the right side, the right clip, the patient had the tamponade as well with a lower quantity of fluid. So the fluid is not a matter of quantity. It's a matter of time. So the right heart is unable to fill it up because something from outside, exactly the fluid, is pushing the right side. So it's not a dysfunction in terms of systole. So etiologically, it's a diastolic dysfunction. So the right ventricle is totally able to have a systole, a normal or normal-ish systole, but when the right ventricle, it's time to expand to do the diastole, it's unable to do it because there's more pressure outside than inside. And these apical four chambers can give us an idea of what's going on here. So when the right ventricle is trying to expand, there's an impending pressure outside. For the massive pulmonary embolism, the blood is blocked inside the lung circuit. So the shock behaves similar than tamponade, but the echo feature is totally different. In the right side, we see enlargement and dysfunction. The right side of the heart is able to acutely enlarge, and this ability is not possible for the left ventricle. So imagine that the outflow tract of the right ventricle is totally blocked, and there's no blood from the right side of the heart to the left side of the heart. So we observed an empty and hyperdynamic left ventricle because the right heart and the left heart are connected through the pulmonary circuit. The left heart, what is going out, each beat of the left heart is the cardiac output. So if we have a block in the middle, there's no cardiac output. That's why you see the left heart like empty, and the hyperdynamic status is trying to compensate the lack of blood coming from the right heart. For hypovolemic shock, actually the concept is really clear because there's no blood or fluid inside the system. So there are possibilities. One is dehydration, the other is trauma, traumatic blood loss, or a spontaneous blood loss. The distributive is based on not only in the lack of blood, but in the low vascular resistances. And there are two main conditions for a distributive shock. One is the most common in our field, in our daily practice, which is sepsis, and the second one is the anaphylaxis. Both hypovolemic and distributive shock have the same ultrasound pattern. In these apical four chambers, we see that again the left ventricle is like empty, is like hyperdynamic, but the right ventricle, which is the key point, looks normal, looks empty as well. So hyperdynamic tachycardia with a normal right ventricle. How to distinguish between hypovolemic and distributive? Because they both have the same or almost the same ultrasound pattern. Remember one of the gold rules of point of care ultrasound: always integration. Always integrates your findings in physical examination, your point of care ultrasound, and the most important thing, clinical information. The patient has fever, the patient looks like dehydrated, if the patient is suffering trauma or blood loss, a visible blood loss, is giving you the clinical information. Under a clinical point of view, we need to do a diagnosis. In point of care ultrasound is a really strong differentiator of kinds of etiology of shock, because a simple heart evaluation can rule in or even rule out between causes. And almost more important than the diagnosis itself is the treatment. And we are going to this scenario: a hypertensive patient, tachycardic patient, looks like there's low oxygen saturation and high respiratory rate. So probably with just this view will be impossible to distinguish between kinds of shock, but the patient for sure has a shock. The clinical information is this: 75 years old male, brought in by emergency medical systems, unresponsive, obtunded, with unremarkable findings in history and really tough physical exam. So the clinical information does not help us at all. We'll move into the point of care ultrasound to see if we can recognize any pattern. So the case number one is this. This is a parasternal short access. The personally short in normal is supposed to evaluate like a circle, like a donut structure. But this structure is not a donut or not a rounded structure for sure. There's something pushing from the other chamber, but by the way, is the right ventricle. So this feature, this image, is giving us an idea that there's a hyper pressure in the right side of the heart. If we move into a four chambers, in an apical four chambers, we'll see this. There's something actually moving. There's an echogenic content into the right atrium moving from time to time to the right ventricle. And by the way, the right ventricle is bigger than the left ventricle. There's a paradoxical movement of the septum. And this for sure diagnose a pulmonary embolism, that in case that we are the patient in a shock, will give us to give some fibrinolytics to the patient. In the case number 2, the clinical scenario will be the same in every single case. The case number 2 is this. We need to evaluate first what view is this, and the view is the parasternal lung. So if this is parasternal lung, there are two valves, especially just one, the mitral valve in the middle of the screen opening. There's no squeezing at all. There's a poor valvular motion, probably not related to the valve itself, but the absence of flow, the absence of strength of the blood that can open the valve. So no motion, there's no problem here that can be solved with fluid for sure. The fluid can be harmful in this case. So in the presence with shock and the absence of movement of the heart, we can implement inotropic drugs like dobutamine for obtaining at least bridge therapy to the diagnosis, to the final treatment. The case number 3 is really clear. There's a lot of fluid around the heart. The right side of the heart, which is anterior, is unable to fill it up, and the heart is moving. There's a swinging heart here caused by the content of fluid around the heart. So what's the treatment for this specific case? In this case, with a shock, with an unstable patient, and this image. For sure, there's just one, the pericardiocentesis. We need to place a needle and we need to take out all this black stuff, all this fluid around the heart to stabilize the patient. The case number 4. The case number 4 depends, because we are seeing a hyperdynamic left ventricle. The walls are actually touching, and this is not normal. If the walls are touching, there are two possible diagnoses. One is the hypovolemic shock, and the other is the distributive shock. One, because there's no blood in the circuit, and the second, because there's no pressure after the heart. So this is called afterload. So the treatment in the first cases, especially if there's a trauma, is blood or fluids, depends or of the fluid the patient is lacking. I mean, in the trauma setting, we need to place blood, and in a non-trauma scenario, we need to place some fluids. For the distributive shock, we need to place an initial treatment, mainly with fluids. But remember, what's the etiology of the distributive shock? The pipe is the second one, the one in the bottom, and the normal pipe is supposed to be the first one, the one on top. So we need to reduce the diameter of the pipes, and this is just achieved with vasoactive drugs like epinephrine or norepinephrine. Of course, in both cases of hypovolemic and distributive shock, we need to go to the real cause, the real etiology, and place some specific treatment for it. So thanks at all, thanks for watching, and don't hesitate to contact in the email address you are looking at in the screen with your ideas or suggestions. Thank you.